Welcome to the webcast Optimizing Mobility, Adherence, and Quality of Life, Mechanically Powered Negative Pressure Wound Therapy. This program is provided by North American Center for Continuing Medical Education and is supported by an educational grant from Acelity. I am Dr. Ralph Napolitano, Jr., and I will be one of your presenters today along with Dr. Christopher Barrett. My practice is Ortho-Neuro, located in Central Ohio, the Columbus area. My disclosures can be found on the activity page. Please note, I will not be speaking about off-label use of some medications or devices in relation to this session. Please see the activity webpage for full information. Our learning objectives for today are the following. Review clinical evidence on the use of mechanically powered negative pressure wound therapy. Recognize the importance of an effective wound therapy in minimizing interference with patients' overall activity, enhancing mobility, and overall preservation of quality of life, and exploring outcomes of a variety of wounds treated with mechanically powered negative pressure wound therapy through case presentations. Negative pressure wound therapy has been studied across multiple care settings and wound types over the past 15 years. This technology is not particularly new. However, today's talk we're going to cut the cord per se and compare electrical standard negative powered wound therapy with mechanical powered wound therapy, which is not electronic. They both have similar mechanism of action. Our story begins at the Stanford Biodesign and Engineering program. 3 graduate level students were assigned the topic of wound care, and in fact they were given this topic to compare traditional powered wound therapy with possibly a new type of technology. Students included a plastic surgery student, an engineering student, and a business student. And they were given literally a clean piece of paper, hence the term clean sheet design, to come up with ways to solve certain problems with traditional powered negative pressure wound therapy. And what they did was talk to clinicians like you and I. They used surveys and compared needs and wants to technology that was available. The device was approved in 2009. So in essence, it combines the simplicity of advanced wound dressings with the proven benefit of traditional negative powered wound therapy, but in a mechanical form. So here's an example of going from portable to wearable. This is a patient of mine. You can appreciate that the device is rather discreet and can be worn under clothing. Shows you the actual device in place. Important is certainly quality of life and adherence to care plan when we're talking about negative pressure wound therapy. Certainly a device like this, in comparison to a traditional powered negative pressure wound therapy device, would most likely be better received and care plan more easily adhered to in such a setting. So if we look at this, certainly it would be less noticed in social situations. There's less noise, less interference with daily activities, as well as less interference with sleep. When we look at mechanical pressure negative wound therapy, there are 3 vital functions that are certainly important to the functioning of the device. Number 1 is the power source, and in this case, without a battery or traditional electrical power source, it's a spring mechanism that's proprietary to maintain constant even pressure. The second piece is the exudate management system, the ability to lock the exudate away in this fashion. It's a gelling type technology. And then third, we need to know when the device is full. There's a visual indicator that performs that task. There's a proprietary hydrocolloid integrated technology with tubing that can be cut to length. So it has this fully integrated microport that enables flexibility and the ability to bend this around different anatomical areas that might be challenging. When we look at this device and compare it to a traditional powered system, you can appreciate that it certainly would be a lot less cumbersome and certainly less heavy. Currently, there's a couple canister sizes. 60 ml is the most common. Therapy setting is continuous. There isn't the ability to change the pressure. There's also no alarms. It's a red visual indicator, as we referenced before. In difficult situations, a hydrocolloid secure ring, which is proprietary, can be initiated as well to help with your seal, which avoids traditional picture framing that is done in traditional powered negative pressure wound therapy. Indications for electronic pressure wound therapy is essentially the same as traditional powered negative pressure wound therapy, head-to-toe indication. Some include diabetic foot wounds, venous leg wounds, plastic surgery applications, as well as traumatic wounds. Contraindications are also similar: active bleeding and/or infection, exposed vessels, nerves, and tendons, exposed anastomotic sites, as well as inadequately drained wounds. Malignancy is another contraindication. We're going to discuss the three key evidence-based articles next. First one is evaluation of chronic wound treatment with mechanical pressure negative wound therapy versus modern dressing protocols. The next study we're going to look at is comparative effectiveness of mechanically and electrically powered negative pressure wound therapy devices. This is a randomized control trial. And finally, we're going to look at specific venous leg ulcers. This study is a multi-center randomized control trial comparing treatment of venous leg ulcers using mechanically versus electrically powered negative pressure wound therapy. Let's look at our first study. 36 patients were enrolled in this study with difficult-to-treat lower extremity wounds. 21 patients were treated with mechanical pressure negative wound therapy, and they were compared to 42 patients, matched control trials, utilizing modern wound care that included cell-based tissue regeneration products or other types of therapies. And what this study demonstrated is that these patients got better faster. However, there was a relatively high dropout rate, and since it wasn't a randomized control study, retrospective studies are inherently limited by design. Moving on to our second paper, this compared the effectiveness of mechanically powered negative wound therapy to electrically powered negative wound therapy. In our second study, 132 patients were enrolled, with 115 completing the study. Patients were sorted in equal groups, with half receiving mechanical pressure negative wound therapy and the other half receiving electronic traditional negative pressure wound therapy. Primary endpoint of the study was wound size reduction, and this essentially demonstrated a non-inferiority to the mechanical pressure negative wound therapy group. Moving on to our final study that focused on venous leg wounds. In this particular study, patients were treated again with either electronic powered negative wound therapy or traditional powered negative pressure wound therapy. 40 patients were enrolled in this randomized controlled trial, and again, endpoint of analysis was wound size. It was found that 53% of the mechanical pressure negative wound therapy group achieved half wound closure at 30 days, compared to only 24% of the electronic powered negative wound therapy patients. Now I'd like to share some cases with you. Our first case is a 74-year-old diabetic gentleman with a history of significant Charcot foot deformity with bone infection and chronic ulceration. He underwent surgical bone debridement and osseous balancing adjunctive procedures. Initial wound care included certainly bone debridement as well as parenteral antibiotics. Mechanical pressure negative wound therapy was initiated in light of the depth of his wound. This is his initial presentation. At 4 weeks, you can appreciate a significant reduction in depth, and at 7 weeks, and again at 11 weeks. Our second case is a surgical dehiscence case. A 71-year-old healthy gentleman sustained a right ankle fracture requiring repair at the hands of my partner, Dr. Nicholas Cheney. He underwent fracture repair without any complication. However, he did develop some postoperative swelling and dehiscence. Standard empiric care, followed by initiation of mechanical negative pressure wound therapy, and a light of some depth was initiated. In this particular case, the institution where he was treated at, we needed to transition to traditional powered negative pressure wound therapy because our trial period for the mechanical device had ended. Ultimately, closure was achieved with a device employing suction blister epidermal grafting. This is him at 9 days and at 18 days. You can appreciate reduction in his depth. With respect to ultimate closure, this is the technique that was employed, automated epidermal harvesting. We'll touch on that now very briefly. Essentially, autologous epidermal pieces of tissue are procured utilizing this particular device. The micrografts are harvested utilizing a surgitome via suction blistering. This is the donor site that essentially shows no wound, and this is managed simply with a film-type dressing. So this technique, employing minimally invasive technology, really cuts down on donor site morbidity. You can use various different dressings when you're harvesting the microdomes, either a non-adherent silicone dressing or a traditional film dressing. This is a representation of the patient experience with epidermal harvesting. The donor site is prepped, takes a couple minutes. The harvester is placed over the patient's thigh. The forearm or the upper arm can be utilized as well. It takes about 30 minutes to quote-unquote raise the microdomes, and then they're harvested utilizing the surgitome. The graft is applied, and the donor site and recipient site are bandaged. So this technique is donor site sparing, it's automated, there's no anesthesia involved, and it's coded similarly to traditional skin grafting. This is our same gentleman now essentially healed at 3.5 months. Moving on to our third case, a 49-year-old gentleman with diabetes presented to our group for reconstruction. He had some surgery at the hands of another surgeon because of arthritis and deformity. My surgical partner, Dr. Nick Cheney, took care of osseous rebalancing. He did develop a small area of dehiscence that became problematic. This wound might look fairly benign, but underneath is a significant amount of hardware that needed protected. We initiated mechanical negative pressure wound therapy at this point in light of the depth. This is at 5 weeks and closure at 7. 9, maintaining complete closure. Moving on to our fourth case, 65-year-old gentleman with idiopathic neuropathy underwent offloading of his fifth ray at the hands of my other surgical partner, Dr. Jeff Gittens. He did very well, but developed some very basic incisional healing issues. Wound bed was optimized, and all he had really was some depth. At that point, we initiated mechanical pressure negative wound therapy. This is his initial wound, showing that small linear defect with some appreciable depth, and closure at approximately 1 month. Moving on to case 5 is a 44-year-old gentleman with diabetes with a long withstanding history of poor sugar control and neuropathy, presented to me for surgical care, was treated by another surgeon initially. Upon initial presentation, it was found to have a large amount of exuberant granulation and even more contiguous bone infection. He required surgery, which he underwent, essentially removing the distal portion of the fifth metatarsal at my hands. In this technique, we used vancomycin-impregnated resorbable bone cement. This is our initial presentation prior to surgery, and this is post-op when we initiated mechanical pressure negative wound therapy. You can appreciate inside the wound are the resorbable antibiotic-loaded bone cement pellets. This is 4 weeks with mechanical pressure negative wound therapy, and at 5 weeks. There was some subtle peri-wound maceration requiring holding the negative pressure device, going to a more traditional advanced wound dressing technique. We reinitiated, and at 6 weeks, we have closure. Finally, our last case involves an ankle fusion revision. 59-year-old gentleman with long-standing arthritis had surgery at the hands of 2 other surgical groups prior to presenting to my surgical partner, Dr. Nick Cheney. What he needed was removal of hardware and a revision in light of his foot deformity. Surgery was complicated and was done in tandem. It required lateral and medial incisions for exposure. Essentially, there was too much bony overgrowth, so leg osteotomies were necessary involving the distal tibia. This is a pre-surgery X-ray showing hardware in place, fairly benign, but you can appreciate the deformity here where the patient essentially was almost walking on the inside of his ankle. There's another X-ray, as well as this view. Surgical technique was rather complicated, involving a tibial osteotomy as well as soft tissue releases. Closure medially was possible, but lateral was not. What was necessary was to apply an external fixator and obtain closure of the soft tissues laterally. In light of exudate, the patient was kept inpatient to manage his pain, and traditional powered negative pressure wound therapy was utilized. When exudate slowed down, transition to mechanical pressure negative wound therapy was then carried out. Ultimately, the goal was to have the lateral side closed so definitive hardware could be placed. This is an intraoperative X-ray showing the external fixator together with the resorbable antibiotic-loaded bone cement pellets centrally as spacers. This is another view, and this shows our traditional electronic-powered negative wound therapy device in place. Post-op day 1, and there's the lateral void. That's a close-up view of the lateral void. Eventually, we did transfer to mechanical pressure negative wound therapy. This is 3 days utilizing mechanical pressure wound therapy, and this is 1 week of every other day changes. Our patient continued to improve, but quite interestingly decided to remove his own external fixator. In my practice career, I've never had a patient do this until now. Our choice here at this point was to proceed with surgical fusion, even though our wound wasn't entirely healed. The decision to perform a nailing technique, a tibio-talocalcaneal nail, was employed. Again, my partner, Dr. Nicholas Cheney, was primary surgeon for this. He did very well and healed uneventfully, with the exception of the plantar heel ulceration, which we don't have photographs of, but we utilized that same suction blister, minimally invasive skin grafting technique to obtain closure. And this is complete closure at this point. Continuum of X-rays, and this is our soft tissue work. There is coding, traditional coding in place for mechanical pressure negative wound therapy. Further information can be found with the parent company. So in summary, benefits to clinicians and patients include indications are essentially the same as negative pressure wound therapy, an off-the-shelf type procurement process compared to traditional powered negative wound therapy requiring pre-approval. Settings are continuous over a 24-hour period. With respect to concern about being functioning during power outages, since the device is mechanical, there's no disruption of treatment. It's single-use and disposable, discreet, non-invasive, and definitely impacts quality of life positively. Thank you very much for your time. I'm going to turn the talk over to Dr. Christopher Barrett.
Well, thank you very much, Dr. Napolitano, and welcome everyone. I'm Dr. Christopher Barrett, and I'm going to be presenting the second part of our discussion today on mechanical disposable negative pressure wound therapy. And for my part of this discussion, I'm going to be taking some of the information that Dr. Napolitano provided to you, some of the background information on the device, and we're going to talk about it, how and why you would use mechanical disposable negative pressure wound therapy, but in a very unique, a very challenging location, and that's the outpatient wound clinic. So what my hope is after my part of this discussion, you kind of have a little bit more insight into what the benefits are for a portable, mechanical, disposable negative pressure device for a certain subset of patients who really live in the outpatient wound clinic, and for really a basic certain subset of wounds that we treat in that location that really are an ideal environment for a type of device like we're discussing today. So I really can't, really have a discussion like this without really talking about a certain group of patients, and that's patients with diabetes and ulcers. And I'm not discounting all of those patients we treat in an outpatient wound clinic with venous ulcers and pressure ulcers and arterial ulcers, but there's a very, very important differentiator between all of those other types of wounds and a diabetic foot ulcer. Okay, and the differentiator is a patient with diabetes who develops a plantar foot ulcer often succumbs to that foot ulcer. The foot ulcer is often the demise of that patient. In fact, if you look at statistics, a patient with a diabetic foot ulcer has a 5-year mortality rate that is actually greater than patients with breast cancer and prostate cancer combined. So I want you to digest that for a second and really understand there is, such a vast swell of support for those with breast cancer. I think every day we see some type of program, a run, some type of support for those with breast cancer, but those with neuropathic foot ulcers really don't have that support, and it's really those of us who treat these patients in an outpatient wound clinic. The choices we make, we make in how we treat these patients can really have a profound and dramatic effect. And it's not overstating that often our interventions, our treatment can save a limb and can save a life. So again, that's why I'm going to really key on this patient population, one of the most common patients that we treat in the outpatient wound clinic, and how important our thought process is for treating these patients. But we can't really just discuss the human factor, okay, for in the outpatient wound clinic. What we really have to also look at is the cost. And I don't think we can really talk about wound care and outpatient wound care without really talking about reimbursement and cost. And there's the reason why I really want to talk about this is just last year there was an article in Value in Health. And this article was really supported and funded by the Alliance of Wound Care Stakeholders. So that alliance, those of us who treat wounds for a living, Dr. Carolyn Fife is a very prominent physician involved with the Alliance who does a lot of publishing and lecturing on wound care, and I really love a lot of the work that she provides. And she was instrumental in working with Medicare to recognize those of us who treat patients with wounds, because as we're going to see in years to come, there's going to be a change in how we're reimbursed and how we're recognized for what we do in the wound clinic. And it wasn't until Dr. Carolyn Fife and her group at the Alliance kind of went to CMS, went to Medicare, and said we have to kind of look at what's happening in wound care in general and the money being spent. So finally Medicare looked at that. So back in 2014, Medicare looked at data, the 5% data set. So they looked at 5% of the Medicare data, and what they found was pretty dramatic. They looked at the total treatment cost and the prevalence of pretty much anything that has to do with wounds. So if you look at the different types of wounds and complications, really covered a broad spectrum of what we would treat both inpatient and outpatient. And the results of this study, the results of this investigation really opened up Medicare's eyes, because what they found was nearly 15% of all Medicare beneficiaries, that's over 8 million patients, had at least one type of wound or complication, as we see listed above. The most prevalent was surgical wounds, followed by, as expected, diabetic infections. But also in cost, the same thing. Surgical infections and surgical complications were the most costly, followed by diabetic wounds. But it was the spending that really opened their eyes up. So what they found was almost $30 to $90 billion were spent in that 1 year treating wounds and the complications of wounds. And the site of service that was spending the most amount of their money was the outpatient area, okay, the outpatient area that I work in and that many of us treat our patients in. So what do you think would be the outcome of this? The conclusion was that this data was going to provide, there was going to be important implications for CMS payment policy. That means what we've already seen happen. So 3 years ago, we had hyperbaric oxygen therapy, a very costly therapy that Medicare was investigating for well over a decade. Well, finally, they cut some of the indications that we treat and really put a dent in the ability to treat patients with wound complications with hyperbaric oxygen therapy. And that was kind of really one of the, really what came out of that study was cost cutting. We look at recently Novitas, my Medicare MAC, implemented cuts in the amount of surgical debridements that we were allowed to do in 1 year per wound, limits in negative pressure wound therapy, limits in non-contact ultrasound, and that's kind of the implications in payment policy that they stated we're going to have to come to really cut some of those costs we're seeing in the outpatient area. But also, what the Alliance of Wound Care Stakeholders was interested in doing is getting Medicare to realize that those of us who treat wounds for a living need some type of quality measures to be able to show Medicare that what we're doing is the right thing for our patients and that we can provide value, because really that's where the future of outpatient wound care is going in, and that's really the future of reimbursement is going to be providing value, okay, and stopping that spending spree that Medicare has now recognized is going on in the outpatient wound areas. So the goal really is to cut costs and to find those who can provide wound care at a value, at a cost, at the proper cost, to save Medicare money. So that's the future of wound care, and that's why I think our discussion today has to really focus in on reimbursement and cost, because that's where our negative pressure device, our disposable mechanical device, really fits into this new paradigm that's going to come down the pike for reimbursement in the outpatient wound clinic, because obviously Medicare saw how much money we're spending. And this is kind of the problem. We know that the type of wounds we see in an outpatient wound clinic are very difficult wounds. Chronic ulcers are vastly different than healing wounds or acute wounds. We know that acute wounds, cells are migrating, cells are alive. They're doing what they're supposed to be doing. We have a healthy extracellular matrix, or we have a healthy incision. There's cell mitosis. There's limited inflammation. We certainly need inflammation early on in wound healing, but in a normal fashion, inflammation will subside as the healing progresses, and cells are actually responding and they're dividing. The problem with the chronic ulcer, it's a much more difficult problem, because we have an unchecked inflammation. So we have overexpression of matrix metalloproteases and serine proteases. We have an inflammatory environment. Our extracellular matrix is being damaged. It can't repair itself, and because of that, we have senescent cells. Our cells are not responding to stimuli. They're not migrating. They're not replicating. There's no mitogenic activity. This is a very, very difficult environment, and what it requires is a thorough understanding of wound healing physiology, but you also have to know your products. You have to know how they work, when to use them, and you have to know their cost as well. So it's a much more challenging and difficult environment to live in, but we know that Medicare, this is all about quality measures, and we have to understand how to use our products, use them properly to provide value to the payers so that we get our outcomes at a lower cost. And that's the challenge with chronic ulcers. Luckily, there's a concept that was developed back in and around 2000 by plastic surgeons called wound bed preparation. And it's a systematic way, an orderly way of looking at a chronic wound, addressing the barriers to preventing that wound from moving on through the healing process. And the goal is to address those barriers and get a wound, like you see in the photos, to take a chronic non-healing ulcer, to address the barriers and get that wound to move into a clean, healthy extracellular matrix with healthy granulation tissue, well perfused, and you now have a pallet, a wound bed, that you expect whatever intervention you're going to provide to close that wound should work because you've prepared that wound bed properly. And that's value. If you can get your interventions to work, you're going to provide value. You're going to get your outcome at a lower cost. That's the concept of wound bed preparation. In 2003, some of the great minds in wound care, the key opinion leaders in wound care, got together in Europe and kind of put a name to a face. They took that concept and made it more understandable, okay, more organized, and they called it TIME. Okay, the acronym TIME. And they took the barriers that were mentioned and actually, broke it down into 4 identifiable barriers in the chronic wound. That's T, which would be tissue, non-viable, necrotic, devitalized tissue. The I is infection and inflammation, and that includes not only bacteria but proteases, because where you have bacteria and proteases, you have inflammation. So they really go hand in hand. And then moisture imbalance, okay, and that's just really dressing selection, knowing your dressings, knowing your interventions, not drying out the wound, not causing maceration, because again, If you cause maceration or desiccation, whatever interventions you're using, you may, unfortunately destroy your progress. And again, that doesn't provide value. That's going to cost money as the wound goes on to non-healing. And then the edge of your wound. Okay, and really the crux of this problem, okay, when you have a non-migrating wound edge, so whether you have epibole or rolling of your skin edge, you have undermining, okay, and you have tunneling. The point of all of this is you have to be aggressive and fix that problem so that you can, again, achieve that healthy extracellular matrix, that healthy granulation tissue, granulating base, where now your keratinocytes, you will get epithelialization of that healthy wound bed, but that requires you to be aggressive. And when I say interventions, the second line in our time principle is the recommended intervention. What I want to mention is if you look in 3 of the 4 barrier areas, okay, T, I, and E, we see that debridement is really the primary intervention that's recommended. So obviously debridement is important. But how important is debridement? Well, let's look at some data. So this is real-world data. This is out of right out of an electronic medical record, and this is looking at a 4-year period, 525 wound care clinics providing data. Now we're talking about 312,000 wounds, and what outcome they were measuring was complete closure of the wound, complete epithelialization, and they were looking at the frequency of debridement and how that translates into wound healing. And what they found was, looking at diabetic foot ulcers, that very important patient population of ours, by debriding the wound more frequently, that is at least once a week or if not more frequently, the healing rate was 21 days. Okay, and that's if you can get your diabetic foot ulcers healed in 21 days, that's certainly what I would say providing value to the payer, and that's certainly an excellent outcome. But look at the difference just by adding an extra week on to your debridement frequency. Just by bringing that patient in every other week, it took over 3 times as long to heal these wounds. And every time you added time in between your debridements, it took more time to heal the wound. Time is not value. Okay, time is money. Time is the potential admission to the emergency room with an infection, loss of a limb, and certainly loss of a life. So time is so important, and we see that frequently, the more frequently you debride a wound, the better they heal. And my question would be, why do you think that's happening? I'm going to answer that question in a couple of slides, but kind of put that on the back burner and think about, why does frequent debridement have such a dramatic effect on healing? But what goes hand in hand with debridement is visit frequency. So again, the more frequently you're seeing your patients and providing wound care and intervention, quality wound care, look at the outcome. So in this case, they looked at a 1-year period with 9 clinics in 5 different states, and they looked at diabetic foot ulcers and venous leg ulcers, over 200 in each group. And their outcome was the median time to heal these wounds. And again, look, the results are so dramatic. So for a diabetic foot ulcer, if a patient was seen at least once a week, if not more, the 4-week healing, 63%, almost 64% of the patients were healed at 4 weeks versus only 2% of those patients if they were seen longer than every week. And how about venous leg ulcers? Let's talk about a dramatic difference. So again, venous leg ulcers that were seen and treated at least once a week, 52% of those wounds were healed at 4 weeks versus 0. Okay, not one patient was healed at 4 weeks if these patients were not seen at least once a week or more frequently. So let's take debridement and visit frequency, put them together, so we have a combination that we now know, just by looking at real-world data, will have a dramatic effect on a patient's ability to heal. And again, I say the future is getting your wounds to heal quickly and getting that quality outcome at lower cost. So if you can heal wounds more quickly, you're going to reduce cost, and that's really the goal, and that's really what's going to be responsible for your reimbursement, and certainly an increase in your reimbursement versus those who can't provide that same kind of value and healing. But let's look at that concept of 4 weeks and why that's so important. So this is, again, looking at diabetic foot ulcers, and this is the late Peter Sheehan's, really landmark study data where during a randomized trial looking at the control group in diabetic foot ulcer healing, 276 patients, and what they were looking at was when we say PAR, the percent area reduction, that's basically the let's call it wound healing. So as the wound area reduces, they looked at in 4 weeks, patients who, the midpoint between patients who at 4 weeks had healed versus those who at 12 weeks had not healed. And that midpoint, that median, was 53%. So what is the significance of that 53%? So patients whose ulcer reduced, okay, by at least 53% at 4 weeks went on to heal by 12 weeks. 58% of those patients were healed by 12 weeks. If those same patients getting that same treatment, those same diabetic ulcers, did not hit 53% area reduction in wound area at 4 weeks, if they did not hit that target of 53%, only 9% were healed at 12 weeks. So 4-week healing, okay, 4-week healing, 53% at 4 weeks, that's a robust predictor of healing at 12 weeks. Now, I just told you that time, okay, if your wounds heal in a timely fashion, that, again, it's a money saving for certainly the payer, but let's talk about complications and what happens to these patients. These patients end up, again, with infections, losing more tissue, oftentimes losing their limb, and then we see the 5-year mortality rate. Certainly with an amputation, that's even reduced even further. So time is money, time is a limb, and time is a life. So important for these patients, these diabetic patients, to have change in wound area, to improve very, very quickly. And that's really talking all about being aggressive. So I went back to you and we talked about 4-week healing. This was 2003 with Peter Sheehan's data. So Dr. Robert Snyder, again, kind of looked at Peter Sheehan's data and wanted to validate that. So he looked at the control groups in 2 prospective randomized trials, and again, looking at diabetic foot ulcers, and what his data really kind of backed up the outcomes and the data that Dr. Peter Sheehan was able to find. And when he looked at the data for his diabetic foot ulcers in these 2 randomized trials, he found that those patients who hit 50% healing at 4 weeks, okay, in the 2 study groups he was looking at, when the diabetic foot ulcers were at least 50% closed by 4 weeks in both study arms, either it was 57% in the first study arm and 52% of those patients at 4 weeks were healed. For the patients who did not hit that target of 50% wound closure in 4 weeks, only 5% and 2% of those patients went on to heal by week 12. So if you kind of look at the flip side of that, 95 to 98% of the patients who did not hit, of the diabetic foot ulcers, who did not hit 50% closure at 4 weeks, only 2 to 3% of those patients were healed at 12 weeks. And again, that's that time period. So we know that 4 weeks is a robust predictor for us to really monitor our patients and the expected healing and getting that outcome quickly. What's even better is in Dr. Robert Snyder and Dr. Robert Warner kind of looked at how about those patients who do hit 50% healing at 4 weeks. So they hit that target, that goal of 50% at 4 weeks, but then why do those patients not go on to healing at 12 weeks, and can we predict that now? So what he found was we can look at that. So now at the 4-week period, from week 4 to week 6, if these patients do not continue to improve or they regress, then we know those patients are unlikely going to be healed at 12 weeks. And in fact, if we look at week 8, if patients are not 90% closed at week 8, it's unlikely that those patients are also not going to heal by week 12. So now we have 3 different surrogate endpoints to look at: 4 weeks, 4 to 6 weeks, and 8 weeks. So as we track our progress, our trajectory to healing, we have endpoints we can now look at and say, are we doing the right thing? Are we getting the outcome that that we expect? And we can predict that by looking at our percent area reduction, our wound healing. So that's a very important aspect of outpatient wound care. We have targets to look at that really are going to have a dramatic effect on our outcomes and really our healing of our patients and their lives. But I asked you that question back when we looked at the debridement rates, and I said, why is frequent debridement so important, and why does it have such a dramatic difference? Well, what's interesting is, and kind of the answer, I think, came out in around 2012 when one of the original authors of the concept of time, I told you in 2003, some of the key opinion leaders in wound care got together, and Greg Schultz was one of those key opinion leaders, one of those wound care specialists who provided some of that data. So in 2012, he kind of looked back at the concept of time that they developed in 2003, and he said, time is now 10 years old. That concept, that acronym is 10 years old. Is it still relevant? Is there anything we should change, or is there anything we should really be looking at? And he said 4 developments stand out. He and his colleagues looked at the data, and they said there's 4 developments that we really see standing out in the last 10 years that kind of moving forward should be a focus. Okay, and number 1 was recognizing the importance of biofilms. And now we know why those wounds that were frequently debrided had such a dramatic effect, had such better healing than those who were infrequently debrided. And it's really because of biofilm, I think. And if you look at Dr. Greg Schultz is one of the leading biofilm experts, and biofilm is a difficult problem, and we don't really have a lot of time to go into the depths of biofilm research and discussion. But to really summarize it, bacteria now, we know bacteria now like to survive and live in a biofilm community. And that's where bacteria get together, they communicate, they protect themselves with that EPS, that extracellular polymeric substance it's comprised of polysaccharides and lipids, DNA, and that protective film or barrier protects the bacteria inside the biofilm. But we know that debridement is an effective way of disrupting that biofilm, turning those biofilm bacteria now back into a planktonic state. And by doing that, when bacteria are in a planktonic state, they are now affected by some of your external interventions, which would be the use of negative pressure wound therapy and topical antiseptics, which Dr. Schultz recognized 10 years ago in 2012, 8 years ago, where negative pressure wound therapy and topical antiseptics are areas we really should be looking at for the future. And we now know that our topical antiseptics have evolved. We have some really wonderful products that we can use now on planktonic bacteria, now that these bacteria are susceptible to our interventions, and also negative pressure wound therapy. So the point of our discussion today in looking at disposable mechanical negative pressure wound therapy is, how about we use these concepts that Dr. Greg Schultz and his group discussed and the acronym of time and debridement, disrupting biofilm, using mechanical negative pressure wound therapy, topical antiseptics, and collagen to reduce proteases, because we know infection and inflammation is bacteria and proteases. Using that combination together to improve our wound healing, at the same time providing value to the payer, okay, using less resources. The fourth, what stood out in number 4 in him looking forward to the future was the molecular biology of wounds. So we now know, we're looking now at the cellular level. Okay, we now understand the types of bacteria that live in the wound basically by looking at their DNA. We have now mapped out the DNA, okay, the genes of the bacteria, of all the bacteria that we now have in wounds. So we have a better way of looking at the wound bed, looking at biofilm, and looking at what's really causing that wound to remain in a chronic state. So this is kind of what we saw, what Dr. Schultz saw in 2012 as the future of wound care, and I think we're certainly here now with a combination of therapies, having a disposable negative pressure device to kind of use that in a way in an outpatient clinic to get better outcomes. And this is what he talked about when he talked about negative pressure wound therapy, and the future of negative pressure wound therapy is using it to help loosen slough and necrosis and help our sharp debridement. So we now know that sharp debridement is so important, and if we combine NPWT in an outpatient clinic and doing that using a device that's really ideally suited for that, and that's a portable mechanical device, a disposable device, if we use that together, we can actually see improvement in our debridement, improvement in granulation tissue, and use it together to support, again, he says, the time principle. So that time principle is still very, very important, still relevant in 2018. Looking at those 4 areas of the wound bed, the chronic wound bed, and using our interventions wisely, okay, using quality interventions that at a lower cost, and negative pressure wound therapy is going to be a key aspect of that to get these outcomes. And that's really what my case studies are going to highlight. And here's the benefits of NPWT. Why Dr. Schultz would mention NPWT is because of all the benefits it provides. Not only does it, we know that for larger wounds we get macro strain and contraction of the wound bed, but also micro strain and cell stretch, which improves perfusion and granulation tissue. We see that with our mechanical disposable device. But more importantly, the other 2 aspects that I really want to key in on is we see that picture with the planktonic bacteria. This is the part of when we disrupt a biofilm and we use negative pressure wound therapy to control planktonic bacteria, remove them from the wound bed, okay, which is so important because bacteria that live in a biofilm, when they're disrupted, they look to reform that biofilm very quickly, usually within hours. In fact, within 72 hours, they return to a mature biofilm, okay, which again is going to really put our wound back into a chronic state. So if we can prevent planktonic bacteria from reforming biofilm, we're going to see an improvement in our wound bed, okay, in our wound healing. And that's really where negative pressure wound therapy comes in, maintaining control of those planktonic bacteria and not allowing them to reform biofilm. And also, we know that negative pressure wound therapy as a whole manages exudate. Well, we know wounds in an outpatient wound clinic tend to be smaller wounds, lower exudate, which is still very important because we know chronic wound fluid is very toxic to the wound bed. It inhibits cell mitosis. We want to get that fluid away from the wound bed, and that's really what I love about negative pressure wound therapy is not only can we control bacteria, we can also remove that toxic wound fluid, that deleterious wound fluid that affects our healing, get it off the wound bed and into a canister, into a container, which again is really going to help if you add all this together. Wound contraction, controlling bacteria, exudate, increased perfusion, increased granulation tissue. There's no other wound dressing that provides those 5 benefits, and that's what I think for a device like our disposable negative pressure wound therapy device that can be used as a dressing in an outpatient clinic for ambulatory patients is really just really the device was designed for those types of patients and for that place of service. So if you really kind of look at the time principle, I think negative pressure wound therapy really could have a key role and really should have a key role as one of the primary interventions because if we go across the board and look at our 4 barriers, by addressing necrotic tissue with debridement, okay, by using negative pressure wound therapy, we, again, keep that wound bed healthy, prevent necrotic tissue reforming, increasing perfusion and granulation tissue, but at the same time, in the eye, we prevent planktonic bacteria from reforming biofilm, which then invites proteases and creates a chronic state, inflammatory state. So we've already affected T and I, but again, with moisture imbalance, we take that chronic wound fluid, remove it from the wound bed, from the wound itself, again, protecting our healthy cells. And at the same time, if we remove, if we use debridement and aggressive wound care to remove pibili and remove undermining and tunneling, we can use negative pressure wound therapy to improve our extracellular matrix, which will then allow our keratinocytes to proceed with epithelialization. So negative pressure wound therapy really can be used in all aspects of time to really improve our outcomes. And this is really where our negative pressure wound therapy device, our disposable device, lives and why it's so important in an outpatient clinic, because patients in an outpatient clinic, okay, are vastly different from those inside a hospital and an inpatient side, because our patients have real-world challenges. Okay, our patients need to work. Our patients may have mobility issues. Okay, there's a risk of fall. Okay, with the power devices, they're heavier and hoses, really kind of present a fall risk. These patients want to maintain their quality of life, and that includes privacy, being able to go out to eat, being able to go to church. Okay, and that privacy issue, patient satisfaction, is going to be part of our reimbursement. It is now. And it's a very important aspect that we have to pay attention to. Again, with these power devices, with the noise they make, and they're cumbersome and they're heavy, they really affect the patient's quality of life. And also patients need to sleep. So we know those of us who've used power devices for many years, we know that that's often a complaint from these devices. So we have patients that have real-world challenges because these are patients that are ambulatory, being seen in an outpatient wound clinic. We now have a mechanical disposable device that we can now use for these patients to provide them those 5 benefits of negative pressure wound therapy, but in a more portable way, okay, a lightweight, portable, disposable device that really is ideal for the size, the types of wounds we see in an outpatient wound clinic, their size, their exudate amount. So what I want to really do is kind of give you some real-world examples, kind of looking at these challenges that we have in front of us. Let's look at patients that kind of fit into that collection of real-world challenges. Let's look at some real-world patients and using the negative pressure wound therapy device or disposable mechanical device to really get better healing and again, to be able to maintain these patients' quality of life. So let's look at my first case study. Okay, and this was back in 2013. This is a 65-year-old patient. Okay, so we're going to talk about a radiation wound. 65-year-old woman with diabetes who previously was treated for breast cancer, right-sided breast cancer, and went through a lumpectomy, radiation therapy, chemotherapy. 21 years later, she presents to her surgeon, and there's some serous drainage from that previous cancer site. So obviously there's a concern for recurrence. So her surgeon does a biopsy appropriately, which they find is now negative, but unfortunately, by creating a wound in an irradiated field, in an irradiated area, which is basically an ischemic area, we now have a non-healing wound. So we have a negative biopsy, but we have now created a non-healing surgical wound in an irradiated area. So there's really only one way of returning perfusion to irradiated tissue, and that's through hyperbaric oxygen therapy. So this patient was referred to our clinic for hyperbaric oxygen therapy, but at the same time, we have a non-healing wound that we have to address. The patient was referred by a plastic surgeon. The ultimate plan was for this patient to complete HBO therapy, have a more well-perfused wound, and then go on to a flap closure to close this chronic non-healing wound. Obviously, the patient was not very happy with the thought of having to go through a very complicated surgery. But we looked at this chronic wound and decided, maybe some simple interventions as hyperbaric oxygen therapy proceeds and returns perfusion, maybe some simple interventions can help us close this wound. So this was a 5-month period, and what I'm going to show you is just some random photos that kind of give you an idea of how we approached wound healing in this patient. So this was over a month into her hyperbaric therapy. We started providing, again, we have an ischemic wound, so we can't be very aggressive early on, but what we can do is provide some light debridement, some collagen, and some negative pressure wound therapy to really start to take advantage of some of that increased microcirculation or perfusion that we're seeing from HBO therapy. So at this point, just give you an example, this was a point where we started our disposable negative pressure wound therapy with this patient with collagen, and I'm going to show you just a couple of slides as we go on. What you're seeing is contraction of the wound and actually some epithelialization. And the reason why at this point we decided to go on with some biologics and some more aggressive therapy was because of this reason. We now have wound bed preparation. We have a well-perfused wound bed because of HBO therapy. We now have a palate that we can provide some interventions, and we would expect the interventions to be successful because we have a properly prepared wound bed that is now well-perfused and clean. So at this point, we decided to use a cryopreserved piece of skin to provide those growth factors and that structure that would allow the wound to, again, improve granulation and perfusion and hopefully go on to closure. So we now have a well-perfused wound bed. We applied the cryopreserved skin, okay, as you see in the picture, but the challenge is the location of the wound. This is in the axilla. Okay, it's you're basically fighting gravity, and you're fighting a very moist area with some scar tissue. So a very, very difficult area to bolster, but with the advantage of a disposable negative pressure wound therapy device with, as you previously heard, the secure ring to actually get good adhesion and prevent leakage in this very challenging area, we were able to provide not only the benefits of NPWT, but we're actually able to bolster that, that piece of tissue, that very expensive piece of tissue, and the hope is that we're going to get the proper effect. So what you see happen now is because that cryopreserved piece of skin provided all those growth factors and structure, we see immediate change. We see improved granulation buds. We see epithelialization of the wound bed. So we now know that we're actually moving on. That wound is now unstuck. It's no longer in a chronic state. It's in a healing state. What we actually did was apply one more piece of dehydrated amnion, now that we have epithelialization, to kind of stimulate, again, more growth factors, more epithelialization, faster healing. And this woman went on to complete closure of the wound with nothing more than the benefits of negative pressure wound therapy via a disposable lightweight device, a couple of biologic tissues, and the benefits of HBO therapy. The real goal for this patient, and the real home run here, was we prevented her from having to go on to get a very complicated flap surgery from the plastic surgeon. So again, patient was very happy. Again, that's patient satisfaction, maintained her quality of life. And this is how we secure the device. This is why when I talk about patients the types of patients we see in an outpatient clinic, this is an ambulatory patient, and this is the device as we used it. But you see here, this is the patient with that fall risk. Okay, she has ambulatory devices she needs for balance. and in the middle of the winter with the heavy coat and with the bags that she's using, she's wearing her negative pressure device on her right arm, but you can see that it's not affecting her ambulation. Okay, it's certainly not affecting her quality of life because nobody knows the device is there. It's completely quiet. It's secure. It's allowing her to get the benefits of NPWT for wound healing, but it's also allowing her to maintain her lifestyle. So, and this is really the kind of the perfect example of the type of patient that really benefits from this type of portable device. So let's look at our second device. So you saw number one in our list of challenges was the working patient. So this was a 58-year-old male who was an HVAC repairman, okay, and worked at a government contracting had a government contracting job right near our clinic. So very interesting case. He was working up in a ceiling, okay, up into a dark area, and he stuck his right arm up into that area to address a broken air conditioner and felt a sharp pinch on his right forearm. So over the course of 72 hours, he noticed that area became more swollen, more red. He went to employee health and was, again, after a week, was referred to our clinic for evaluation. Now, what we found was this patient there was a suspicion that there was a venomous insect. We did not have, the insect was not visualized, so we could not confirm or prove that. But when we looked at him clinically and kind of took his history in, it really became obvious to us that he was bitten by some type of insect. And what we saw was a very red, swollen, what looked like an abscess. This patient was referred to hyperbaric oxygen therapy as well because there's anecdotal evidence that HBO therapy can actually inactivate the toxin from the bite, from the insect, and limit tissue damage. But after that patient was seen and referred on day one, we did an IND of the area, and this is what we found. So this is kind of why it really confirmed our initial diagnosis is what we see is this wound, there was no pus, there was no purulence, there was some serous drainage, but this was essentially tissue destruction. There was muscle destruction. We were down into the deeper layers of tissue, exposed muscle. Now, again, this area was very inflamed, so what I decided to do is pack this area with a silver alginate for a week to bring down that bacterial level, bring down the inflammation in the wound. And what I did was, after that initial week, again, I wanted to be aggressive. We have a very large, deep wound in a working gentleman, okay, who did not want to miss any days from work. This gentleman would show up every morning at 7 a.m., get his hyperbaric oxygen therapy, and in 2 hours was back at work. The way I was able to allow him to go back to work and still provide him with quality wound care, I saw the benefit of negative pressure wound therapy for this wound, but he would not be able to take a powered device and continue the work. He would have to go on disability. The gentleman was absolutely adamant that he did not miss work and go on disability. Being able to provide NPWT with a disposable portable device, a mechanical device, again, allowed him to get the benefits of NPWT and still remain at work. So this is how we use the device. We place the dressing on the arm. What I would do is cover this arm with a compressive dressing, elastic dressing, stocking, 2 layers, and then I would use the second layer to cover the canister and kind of put the canister in between. So this gentleman was able to have full mobility of his arm. He was able to go back to work and continue on his job. And what you're going to see next is this is after 1.5 weeks. This is after 3 negative pressure dressings. We had complete wound bed preparation, complete granulation of the wound. We have a healthy vascular wound bed. So again, this is a palate where you know your interventions should be successful. And what we continue to do is just use disposable negative pressure wound therapy, nothing more. No other interventions, and we got this wound down to close to this point. This gentleman went on to complete closure with nothing more than 17 hyperbaric oxygen therapy treatments and negative pressure wound therapy and 1 week of moist wound dressings. I would call this a very, very value-based healing. We were able to keep this gentleman ambulatory and working, very, very good outcome, and a very happy patient, very satisfied patient. Let's look at a venous leg ulcer. These are the most common ulcer you see in an outpatient wound clinic, so there's certainly a great opportunity to bring in the benefits of NPWT to these type of wounds, and they do very well with this type of intervention. As you saw with Dr. Napolitano and some of the evidence, on the level 1 evidence for venous leg ulcers, they do very, very well with negative pressure wound therapy, and they did very, very well with this disposable negative pressure wound therapy device. So this is a 73-year-old gentleman, long-standing VLU, non-compliant. What one of our physicians had done was place a biologic tissue on the wound the previous week. I was called in as a consultant to kind of take a look at the wound because unfortunately we had a very, very bad outcome after the first week. So if we talk about value, we now had a very poor response to a very expensive biologic graft, and it mainly came down to poor exudate management. So we talk about the TIME acronym and the principle of time. If you look at that M, very easy to overlook the importance of moisture balance. So here we see a leg ulcer, a venous leg ulcer with unchecked exudate. So not only did we have, we went past maceration onto peri-wound damage. So we see all these satellite wounds caused by unchecked and uncontrolled exudate. So obviously we have proteases, we have inflammation, we have very poor granulation tissue. So if you look at time, we're kind of covering that all 4 barriers. So we have a non-migrating wound edge, poor granulation tissue, lots of infection and inflammation, biofilm, and poor moisture control. So this is a perfect opportunity to bring in very simple interventions that we all have in the clinic, and that's number 1, collagen, okay, as a sacrificial substrate to control proteases. And actually this type of collagen can facilitate some improved granulation tissue and extracellular matrix production. So we kind of treat it as a tissue product. We put a non-adherent barrier over it to protect it, and then we use our disposable negative pressure wound therapy device to provide not just a bolster, but all those other benefits, controlling the exudate, providing a bolster for the graft, and again, just in general, protecting, and this is kind of the real benefit for having a hydrocolloid dressing as your sealing agent. Okay, all those peri-wound, all those wounds that were that those irritations caused by the uncontrolled exudate, we're using the hydrocolloid as a primary dressing. So we don't have to do anything more than use our sealing barrier, our hydrocolloid, as our sealing agent for the foam, but we're also treating our wounds with hydrocolloid. So it's a very convenient way of kind of treating 2 different problems at the same time. The mainstay for venous leg ulcer treatment is what? It is compression therapy. So we don't want to stop compression therapy while we do our negative pressure wound therapy, and because of that, we can still do that with our disposable device. So what I did was use a 4-layer compression over on the limb, but over our disposable negative pressure wound dressing by doing this, just by creating an aperture for the port and the hose, so we don't compress it, and it allowed us to provide not only compression but NPWT for this patient and his chronic venous leg ulcer, and this is 3 weeks later. So we see what happens when we provide simple interventions. NPWT, we did provide antiseptics after every debridement for this patient. We use hypochlorous acid as a 2-minute soak, which again, we've now created planktonic bacteria. We control that planktonic bacteria collection with hypochlorous acid, and then to prevent those planktonic bacteria from reforming biofilm, we use our reticulated open cell foam, our negative pressure foam, and our disposable device to provide not only exudate control, but also using that collagen to control proteases with compression. And in very short order, we've not only healed the peri-wound, but we now have epithelialization. We have excellent granulation tissue. This is another example of, perfect example of wound bed preparation, and nothing more than negative pressure wound therapy and collagen took this wound to almost closure, and one more application of compression and a moisture balancing dressing. This patient went on to complete wound healing. Let's look at another challenging case. This is a post-surgical hand wound. So I was called by a local hand surgeon who had a 67-year-old woman who he had done a Teno suspension surgery on, and unfortunately this wound post-operatively became infected, required reopening of the wound, debridement, reclosure, and unfortunately went on to a second dehiscence, which again required a second surgery. But I was called because the surgeon was concerned that the patient had a very small but deep wound down to the surgical anastomosis, and there was a great concern that if this anastomosis failed, this patient would have permanent disability of her thumb. So I was asked if there was anything we had at our wound clinic for very small, deep wounds that we can get this wound healed up very quickly. And certainly we have that ability to address small, deep wounds, not with a bulky powered device and a DME device, but now we can provide that off the shelf in a very portable way that allows this patient to maintain their quality of life. So here's what the wound looked like. Again, small wound, but very, very deep, over a centimeter, right down to the tendon. Okay, so we're going to use our negative pressure wound therapy device, our disposable device, which again is a mechanical device, very portable, lightweight. So here's how we applied it using the secure ring. We can customize the dressing to a smaller area. Okay, and this patient also is wearing a spica brace. So we have to incorporate that into our dressing, which again provided a challenge. But again, having this type of device makes it so much more simple to, again, incorporate her spica brace and our negative pressure canister into a compressive dressing, and we use that as our holder, if you'd like to call it that. And she maintains complete mobility of her right arm. And again, this is 3 dressings, which would usually comprise about a week and a half. And we get complete complete granulation of the wound. So now we have, again, wound bed preparation. Some of the irritation peri-wound was from her getting the dressing wet. It's only a limiting factor. She came back 1 week later after moisture dressings changed every day, moisture balancing dressings, and a topical steroid. Came back completely epithelialized. So again, if we're going to provide value to our patient and to the payer, this is the type of device, this negative pressure wound therapy device, that's portable, disposable, mechanical, doesn't affect quality of life, gets very, again, for smaller wounds that are low drainage, this is an ideal device to get that wound closed, not affect their quality of life, and certainly provide some value to the payer. Let's look at another. This is an 83-year-old woman who, as expected, walking on a ladder, suffered a traumatic injury, hematoma, a large cavity wound, very large depth, okay, way over 10 centimeters. When I probed this wound, it actually tracked up the fascial plane proximally. So what we did initially is pack this wound with hypochlorous acid soak gauze. Okay, and what we saw after 3 weeks to a month is a very, very clean, healthy-looking wound, but with a shelf, a little bit of depth. So how are we going to address that? I mean, certainly that's going to take some time to close that down, but if we use standard dressings, but again, having the ability to provide a very small, lightweight, portable device on this very healthy and ambulating patient who did not want to stop ambulating and really did not want to affect the quality of life. She was a busy woman with grandchildren graduating and really had a vacation coming up. So again, having a negative pressure wound therapy device like this, I was able to customize the dressing to the shape of the wound using reticulated open cell foam. And you're going to see, this is 3 days later. Okay, from 6-1 to 6-4. In 3 days, we almost 80% of that shelf, that depth, has now been resolved with negative pressure wound therapy. So again, I like to bring in very simple interventions, NPWT and collagen, because we know a lot of these chronic wounds have proteases, which are kind of delaying healing, keeping it in a chronically inflamed state. So I added some SIS, some collagen dressing with extracellular matrix. Again, customized dressing, bridge dressing, was able to do this, okay, in the course of 10 days. So we took that wound from that size and depth down to a very manageable wound with no depth, and now we have, again, a well-perfused, prepared wound bed. So for many, many options for interventions for closure, we decided to use epidermal harvest graft. This patient was set to go on vacation in exactly 4 weeks after this photo was taken. So we brought the patient in just before her expected vacation. We had complete epithelialization of the wound. So again, simple interventions using simple devices that are very, very ideally situated for patients who are ambulatory in a clinic who want to maintain their quality of life, and we get the outcomes very quickly at a lower cost. And our last case for our discussion, a diabetic foot ulcer, plantar neuropathic ulcer. Again, for offloading, we're going to use the gold standard, the ideal device for healing plantar DFUs, and that's a total contact cast. But now we have to incorporate a negative pressure wound therapy device, which again could be a very large challenge for our standard power devices, but let's show you how we can use them together, our disposable mechanical device in getting our outcome, our quality outcome. So here's the initial presentation. Unfortunately, this patient refused total contact casting, which is really was a big problem, and refused on initial presentation, refused over a month later, and it wasn't until 11/28, a month and a half after initial presentation, that this patient eventually decided to, with some of my discussion over the complications this patient was likely to encounter and the risk of amputation, decided to go with the total contact cast. My expectation was this patient would go on to heal very quickly, and we had some initial success with that, but unfortunately after 4 weeks, from week 4 to week 6, the wound stalled. Okay, and the concern was, what is causing this wound to stop healing, even though we had good progress? So we know that we looked at circulation, and we knew that was satisfactory. In fact, it was excellent, and there was no exostosis that was preventing this wound from closing. So my thought process, and if you look at Greg Schultz and what he mentioned back in 2012, one of the biggest problems we have today in chronic wounds is biofilm. So this became a stale wound, a chronically inflamed wound with biofilm. So how do you address biofilm? We went in and aggressively debrided this wound. How do we address the proteases? We added collagen, ORC. And then we also used our offloading device with negative pressure wound therapy. So we're going to be very aggressive here in getting this wound unstuck from the inflammatory state, getting better granulation tissue, and getting this wound to close. And what we found was, by adding NPWT using the ring, again, that gives us a really robust seal. This dressing is going to be under a total contact cast, so we really want to minimize the risk of leakage and maceration. So this is how we use the bridge dressing, and to protect the patient's skin from the hose. Okay, we use the foam dressing underneath, and what you're going to see is this patient went on to complete closure after 2 weeks. Okay, after providing that intervention, we provided 4 casts. That's 2 casts a week. So in 2 weeks, this patient went on to complete closure just by addressing the barriers, which were likely infection and inflammation in necrotic tissue. So we kind of did all 3 together, using negative pressure wound therapy as really our mainstay of treatment, and the total contact cast. So this is really the take-home for our mechanical disposable negative pressure wound therapy device. It's patient satisfaction. When patients, as you saw in the study, when patients have the ability to wear this device and use this device, they report less effect on their quality of life. They're able to maintain their quality of life. They're able to go out to dinner. They're able to go to church. They're able to go to work. Okay, so again, in social situations, there's no noise. People don't see it. There's no questions. And again, this is going to be one of the mainstays if you look at the triple aim of healthcare, and that's improving outcomes, providing value, but also providing patient satisfaction in your interventions. And we have a wonderful device that does that for the outpatient clinic for the types of wounds and the types of patients we see. So in summary, this is really going to augment the ability to provide negative pressure wound therapy for all of our patients, because we have the powered device. We already have are well versed on how to use that device. So we still need our powered devices for that subset of wounds, high drainage, larger size, but we know that when we have smaller wounds with lower drainage, we have another alternative that's ideal for ambulatory patients, so we kind of use them together. And for all these reasons, wound bed prep, skin graft bolsters, small deep wounds, as you saw, elderly patients with mobility issues. We saw all of these in the case studies. So we can now also use it with home care patients, which is, again, a real benefit for us to use, to get these outcomes in a team approach with your home care agencies. So it's very important that when this is a medical device and it requires training, you definitely need to get some hands-on experience with it. So that's where not using it on the worst patient to begin with, use it on very simple wounds, very simple interventions, and you'll see the benefits, and you'll be able to kind of incorporate it into your practice and get the same kind of outcomes that I'm seeing. So this concludes our presentation. I want to thank you for your participation and for your attention, and I want to say thank you very much.